We are going to talk today about training with pain.
Pain, like the way that I describe it, it's just a threat response. Okay, like at its most simple bit, if your body feels threatened, you're going to have some response of pain. All of these factors, biological, this is the thing that most of you assume is pain, which is like torn muscle, ligament sprain, et cetera, et cetera. Psychological is like what you believe is happening, right? Which is what's going to be the driver of a lot of what we talk about. And the social is Dr. Google and like what your CrossFit coach that doesn't know shit about anything says is wrong with you when you have pain when you kip. Okay, if you're a CrossFit coach, I'm sorry, you know everything. Your other coaches. So actual tissue damage, okay, or sensory nervous system issues, beliefs, and outside influences, right? And all of those will create this response in this either emotional or biological or non-biological response to pain. So if we think it's gonna hurt, the body will be there and it will try to protect us from it. But what we're gonna talk about is why that response and that protective response isn't always accurate, which is why pain is not an always great representation of what's actually going on or even something that needs to be addressed.
The problem with imaging, and the reason why I don't love imaging, of course, if you get in some sort of traumatic event, like if you get into a car accident and something happens, of course, go ahead and get imaging. But I think personally, people rush too quickly from like, oh, my shoulder hurts, like, not at 100%, I'm gonna go get an MRI, right? I think people rush too quickly to go and get imaging. And why is this? Because we wanna know what's going on, right? We think, oh, let me go get an MRI, let me see what's going on. That has to explain what I'm feeling, right?
Wrong.
That is never the case.
Wrong.
If I were to take an MRI of everybody sitting in this room, including myself, CJ, everybody, say we were looking at everybody's shoulders, okay? We could tally up how many people actually have pain.
I have two torn labrums, MRI confirmed.
Okay. Right. So.
Did anyone see me do bar muscle ups today? Yeah? Oh, wow, how could I do that? How's that possible? Oh, it's amazing. No, I don't feel pain, exactly. Go ahead, I'll let you continue.
But we could be looking at everyone's shoulders on these MRI results, and we can look at who actually has symptoms. The people that have symptoms may not actually have anything wrong on an MRI. So relying on an image, an X-ray, MRI, CAT scan, whatever, to tell the whole story is incredibly irresponsible because it's not going to actually give you the answer that you're looking for. So I don't know if you guys have ever been to PT before or gone to a doctor and they, treat based on what they see on an image. That's wrong. We want to treat based on what we see in the person and what the person presents with. So for example, CJ can come see me for PT. He could have a confirmed labral tear, but if he doesn't necessarily present with that way, like I'm not going to treat what his MRI says. I'm going to treat what he comes in with, right? So a lot of people just rush straight through to get imaging, and I think it creates this fear in us of like, oh my God, I have all of this wrong. I need to do something about it, right? And of course, your doctor, maybe a surgeon, is going to say, oh yeah, you need surgery, right? Because that's what they do for a living, right? So of course they're going to say, consider surgery, this and that, but I never, ever, ever recommend any type of surgery to anybody without trying conservative management first. And what do I mean by conservative management? PT, any sort of rehab, you definitely need to try that first. So any questions there? Does that all make sense? Has anyone ever experienced that fear of like, oh my gosh, I have this like crazy thing on my MRI, I need to do something about it?
But the body will adapt, right? So I have two torn labrums. I've had the right one since like I was like 17, and the left one since maybe I was like 24. So we're 10 years in now. And have I had shoulder pain? 100%.
When we say, how do we get rid of pain? A lot of people, like, their jaw drops when I tell them that the way to get rid of pain is usually the same way that you got hurt, right? Like, I can't tell you how many times I see patients where it's like, oh, like I was squatting and like my knee started really hurting me and now I'm just like really afraid to do squats. What do we do? Squats. Maybe not full depth, maybe not super heavy, but what do I have them do? And we're gonna talk about this in the next part here, but what we could do is a goblet squat with a tempo to a box. You know, we can modify some factors that allow us to get some load through their system that they can tolerate. And that's going to be the pinnacle of what we're going to talk about now, to talk about how to get rid of the pain and also train with it. Any additives here?
Stress is good until it's bad, right? Stress is how we get bigger, stronger, faster, more emotionally capable, spiritually capable, physically capable, etc. We stress the body. But does anyone know how bones get stronger? Compression. Compression, right? They're a compression-biased tissue. The more you load them compressively, the stronger they get, right? Osteoporosis is unloaded. People, you know, weightlifting is bad. It's not. It's really good, obviously. That's why we're here. But how do you break a bone? You compress it too much, right? It's the same exact stress component, except it's a little too much. How do muscles get stronger? You fucking yank on them a lot. How do you tear a hamstring? You yank on it really hard one time because you didn't sprint for 10 years and you thought you could race your buddies for fantasy football draft pick, right? Which is what you see on Instagram all the time. It's the same exact stimulus. It's just a little too much. So stress is good until it's bad, right? It's called a ceiling effect. Also, to create all of these things, we have to stress at least a minimum amount. So I call it the stress window. We have to stress a minimum amount to create modification, adaptation, and change. But that window is finite, and we only have so much until that stress is no longer good. And once we're injured, that window shifts down, right? So say if it's on an arbitrary scale of 0 to 10, 10 being an injury point, 9 being the top of that ceiling. Once we're injured, however we got injured, doesn't matter, doesn't even have to be stress related. It could be social, psychological, you woke up, bad day, bad sleep, etc. Your window alters, okay? And so that window is what this is, right? We stress within the window, which is why some pain is fine. And I don't want to jump too far ahead, but so you have to stress a certain amount to create this tissue remodeling, right? Mechanical loading. Stress will reduce the pain if it's within the window, but once we're injured, that window is lower. So what was deemed normal or within your window is now deemed excessive, right? And that's one of the hardest things for people to grab, especially your ego. You're like, oh, you know, I could do muscle ups, but I hurt my shoulder, and then now I'm building back into muscle ups, and you just start like taking swings of muscle ups again. And you're like, oh, I re-hurt my shoulder, it's never gonna get better. And it's like, no, you just don't make good decisions. And what you're able to tolerate is just much lower currently at this point, and it will get back up. But you have to work within the window, and that window alters based on if you're symptomatic, if you have like a full cup, right? Like you have other reasons why you might be in pain, et cetera, right? All the other factors in life. Allostatic load is what we call it. We're not going to go into the cup analogy. We'll never get out of here. Okay. Does that make sense? Right? Does that kind of like play it on the road? That's why mechanical loading works, right? Because it creates stress. The body will adapt. But that window changes, right? Like, does anyone know who Chad Wesley Smith is? The guy who owns Juggernaut Training Systems. Anyways, he's a 1,000-pound squatter. Well, his rehab squat and CJ's max squat are probably really close. Actually, his is still probably a few hundred pounds heavier, right? You know what? Shut up back there, right? You know, he's blown his patellar tendons out, or, you know, like, I don't know, 4 times now. So, but it's all in the same spectrum. There's just how it reaches the person, right? So something that might be 500 pounds for him, full rehab, low stressor, is a max load for me, right? And so it's all on the same spectrum, but we just have to find that dosage, and that's what Melissa's gonna talk about now.
Yeah, so what we're gonna go into next, we like to call this the staircase method. So we're basically finding...
Be still, my heart.
We're finding a spot that we can tolerate some sort of irritation, and we progress from there. So first question I always ask my patients, especially during any evaluation, my clients when I'm chatting with them, what makes it worse, right? So whenever you have any pain, irritation, you should know how that pain or irritation comes on. I included knee pain, shoulder pain, and back pain here just because those are the 3 most common injured joints that I see clinically and that my clients have. So a lot of the times with knee pain, it's usually either squatting or lunging. Those are 2 big ones for that. If it's shoulder pain, a lot of the time it's kipping. A lot of the time it's pressing overhead. and back pain is squatting and hinging. So just something to think about if you guys have symptoms is what makes my symptoms worse, okay? Once you have those movements in mind, then we can drop down to step number 2. How bad is it really? And this is a tough question to ask people. Can't tell you how many times I have patients come in, they're like, well, I have a really high pain tolerance.
Just to be clear, if you have ever said that, you don't have a high pain tolerance. 100%. It's a fact. You want to know why? Because you're in there talking about it. You don't have a high pain tolerance. You're fooling yourself. You're like, oh, if I hurt, that means it's really, really. No. You're just confused. You're just confused. I promise. All right, I'm done.
So, yeah, so how bad is it, okay? So, like I said, this is a tough question to ask people, and they're like, oh, I don't really know. I'm not good at these scales. But how I explain it is 0 out of 10 is no pain at all. 10 out of 10 is like, I need to call 911 for you right now, okay? And this is how we're going to differentiate pain versus irritation, what's okay versus what's not okay. So 0 to 4 is that irritation, that's okay. 5+ is that pain, that's not okay, all right? So when you're training and you're doing some kipping pull-ups and you're like, it's like this 3 or 4 out of 10, but it's not getting worse, that's okay, I'm okay with that. If it's progressively getting higher, like, oh, we're reaching a 5, 6, maybe even like a 7, that's when I want you to cut it, okay? Does this mean we're actually hurting ourselves more? No, not necessarily, but we could if we keep going, and it's likely just going to piss off all the other tissues that are in that area, right? So, like I said, above 4 out of 10, 5+, we don't want to do that. We are then going to move on to the next step here, or if it's below 4 out of 10, you're good. Step 3, if it's above 4 out of 10, there are a multitude of different ways that we can modify what we're doing, okay? So first, you can obviously change the load. If a lot of the times pain that we experience in the gym is related to, you know, the load of whatever we're doing. If we're doing heavy shoulder presses, if I make it lighter, it feels better. Great. That's one thing we can modify. We can always modify the volume, okay? A lot of the times injuries are very sensitive to volume, so it's like, like I have this elbow thing and usually I do okay, but sometimes if I do a lot of overhead or if I do a lot of swinging on the bar, like 3 times a week, that's when I normally feel it. If that's you or someone that you know, then we just have to make sure that we're cognizant of how many reps we're doing, right? If we're staying below a certain threshold that we're able to tolerate, that's going to be okay. ROM, range of motion, we can modify. So one of my favorite things to do is a box squat for people with knee pain. Usually people respond to it super well. For back pain, if we don't want to pull from the floor, if that's painful, we can elevate the bar and pull from an elevated surface, so we're still getting that load. So we can change that range of motion through which we are doing the movement. One of my other favorite things to do is change the tempo of the movement. This is also inherently going to change the load because if you're moving it slower, you can't lift as heavy, right? So I see a lot of people that come and see me for tendon issues or any sort of tendon irritation, and tendons respond really well to tempo. So what this is, for example, if I'm working with someone that has shoulder pain and they have problems pressing overhead, I'll do some sort of like landmine press where it's 3 seconds up and then 4 seconds down. So that is 7 seconds that your body and shoulder are under tension. What did we talk about here? That tension, that loading, helps to build the strength in those muscles, those joints. It helps remodel those tissues, those tendons, and it helps with pain reduction. So the more time under tension that we can spend, that we are in that tolerable irritation range, the better, because that's more load, that's more tension. But again, we need to make sure that we are in that 4 or less out of 10 range. Cool? Again, so the tempo and then movement selection. So like I was just saying with the landmine presses, if I have someone with shoulder pain that doesn't do well pressing directly overhead, say for example with a strict press, we can change that to a landmine press, okay? So just some rules. When you are working with someone, say for example, they have 4 out of 10 pain when pressing overhead, but it goes away as soon as they're done. That's great. you know? It's okay to have general like soreness in an area after doing something intensive to that joint. We just don't want it to be like, okay, this point right here is really sore, like that really pinpoint specific area, okay? If you have pain 24, 48 hours later that's still lingering, you likely overdid it. If there's a little bit of soreness for a couple hours after, that's okay. But if you're feeling pain, discomfort, that is, like I said, 24 to 48 hours, you probably overdid it. And that's the really tough part, because it's like, I feel great doing the movement, but then I'm paying for it days later, right? So that's when you have to be really cognizant of what you're doing, how long after it's bothering you. And it's like, okay, well, I did a bunch of kipping pull-ups, you know, a day and a half ago. This is likely why I'm feeling that. So we may need to modify that way and bring reps back. Anyway, movement selection, all that stuff that we just talked about. Is it pain or is it soreness? Yes. If it's generalized,
Yeah, so it's more generalized.
so that sounds kind of like more like DOMS.
Yeah.
So when I say DOMS, I mean delayed onset muscle soreness. And what that is 2 days after a movement, you're like super sore. So for example, like one time I went into squat for one session. The next day I was sore, but I was sore the day after that. So that's likely what you're referring to, and that's okay. Yeah, that's totally okay. That's a little bit different than what we're chatting about here. The DOMS is a little bit different. That's more of a response to exercise where, and you can jump in here if I'm rambling, but that's more of a response to load and could be volume as well, but that's not necessarily pain or irritation. I mean, it can be irritation or pain if you continue to train. For example, if your abs are sore and you do 50 toes to bar, 100 toes to bar that day, it can turn into pain and irritation, but that by itself is not the same thing.
Yeah, so most of the stuff that we feel from like training is more DOMS related, right? And a good way to sort of define the two is like, if it's muscle belly, it's probably muscular soreness, DOMS, et cetera, right? Like if it's in the muscle belly, unless you tore it, right? Unless you had a pull or a strain or something like that. Most of those things are gonna be like in the muscle belly, like in the biceps, like in the quads, hamstrings, or like in the like erectors, like from a volume deadlift or something like that. And so that's a pretty easy way to kind of distinguish the two. But if you didn't have some sort of pain prior and you did like, I don't know, you did Murph, you're like, wow, my legs are really sore. That's different, right? But if it's like in the joint, hurts to raise your arm up, like in the joint, then maybe we're starting to feel, maybe some pain there as well. But it's an easy way to kind of define the two. It's not 100%, but muscle belly, muscular soreness, like joint pain specifically, probably more of like this pain irritation. Guys, when we do, you've done gymnastics for like the last, 48 hours, like your shoulders are probably not going to feel great. Like that's totally normal, right? This concept that pain is always this indicator that something is wrong is the whole driving point of this talk. Pain is not a great indicator that something is wrong. We train fucking hard. Kipping gymnastics are not inherently like longevity driven for the joint, right? I'm not saying they're bad or dangerous, none of that nonsense. I will go to bat to say that CrossFit is safe. But if someone's like, hey, I want my shoulders to last when I'm 100, I'm probably not gonna say, all right, we're gonna do muscle ups. Like, I'm probably not just gonna like throw that one out there, right? It's not inherently like a great way. You're sore, right? And you can be joint sore for a little bit, that's normal. Assess what you did, right? So the pull-ups, right? If you did, Murph is another great example. It's like, well, we did 100 pull-ups. If it's something that's happening consistently over and over and over again, what was the thing that I said earlier? We need to look at our training, not all the other stuff. Right? So maybe we're still doing a little too much, right? If it's getting to that if it comes down in 24 hours, most of the time, it's probably not that big of a deal. But if it's getting up to like a 7 or an 8 for like that kind of sucks, right? If it's not changing at all, it's been happening for a while, then it's probably fine. But I would probably suggest to maybe bias a little more strength, strict work instead of the kipping, and it's probably just an exposure thing, right? Like, but it's okay to be really sore or like even have. If I were to get up and do 50 bar muscle ups in a workout, my shoulders, like this is not gonna feel great tomorrow. That doesn't mean I'm injured, right? It just means it's like, hey, you did a lot, right? Or if I were to do a 10 by 10 squat, right? My knees might be really sore tomorrow, my hips might be really sore, but that doesn't mean you're injured, right? Like, it's this soreness, irritation. It could be like a 7 out of 10, but like, you have to expect that you're not gonna feel great after an intense session with a lot of gymnastics or a lot of like dynamic joint challenging patterns. Does that make sense? Right? Like, those things are super normal, right? Now, if it's to the point where you do a session and like you can't lift your arm up for like a week, okay, obviously we did too much, that's way too much, right? But within the 24-hour mark, it's probably fine, you know, or even the 48-hour mark within that soreness. Like, you can't expect just to walk out feeling like roses every time, you know what I mean? It's just, that's not super realistic.
This is what, when I say like above or below 4 out of 10, this is during the movement itself, like while you're actually in the moment, not necessarily after. But now that we've kind of introduced the feelings after the fact of doing a movement, does that all make sense to everybody about how you can kind of look at that and be like, oh, maybe I should change something, maybe I'm good. Does that all make sense? Okay, cool. Last thing here. So what CJ was talking about in terms of that window that shifts in terms of your tolerance to certain movements with certain joints, that window, like he said, can shift, and these factors, stress, diet, and sleep, have a huge impact on that window, the size of that window, all of that, where it is on that scale. So inherently, if you are under a lot of stress, whether it's life stress, work stress, relationship stress, anything like that, that is going to shorten your window because your body is already under stress. So let's add more stress and more load to the system. You're just not going to have as much tolerance or wiggle room in that window. Does that make sense? So more stress in general, we don't want to add a bunch of other stress to that. Diet, when we talk about that, a lot of people don't think about how healing, tissue remodeling can be a metabolically expensive process, and what that means is it uses nutrients and resources that you have that you get through food. So sometimes some people may need to eat a little bit more when they are healing from an injury. You can't expect to get better and feed yourself 1,600, 1,400 calories a day on top of training. That's just not going to happen. So we need to make sure that we are fueling ourselves appropriately to be able to facilitate that healing, because it is blood cells, it is nutrients that we get from our food. And then sleep, as we already talked about, sleep in itself is restorative. If you are not sleeping, you are not going to heal. So that is just point blank, 100% true.
What did you say, Melissa? Maybe rewind it, listen to it again. If you're not sleeping, you're not going to heal. Sleep is the most important factor to help you recover from workouts and also recover from injuries and rehab from injuries. Sorry, I've lost my voice. I just got back from the 2025 age group CrossFit Games where I was talking and teaching things, and that's why I have no voice. I promise I'm not sick. I'm actually sleeping very well thanks to Thirdsy. If you want to grab a bag of Thirdsy and sleep better, proven by science, proven by the Oura Ring that I use every night, go grab a bag. It has science-backed ingredients and it'll help you fall asleep faster, stay asleep throughout the night, wake up feeling refreshed, and that's just going to help you recover, whether it's from an injury or from your training. So again, QR code here or go to thirdsy.com, use the code WODprep15. I promise it works. I would never promote something that doesn't work. I use it every night and you should too. Try it out here.
So if you don't have these 3 things in check, or at least thinking about these 3 things, but you're doing everything else right, you are going to be fighting an uphill battle, because the factors that you can control, which are likely these, and your training, stimulus, load, all of that, those are the things that you, like I said, do have control over. So if you are not dialing those in, you are just going to be, like I said, fighting an uphill battle. You're not going to be able to get ahead of that recovery curve.
Yeah, I mean, I would always try to go heat first. If heat helps, prioritize heat, always. You know, you can't overheat something, right? Always prioritize heat. I mean, I don't know. I can't remember last time I told someone to use ice besides Jen, right? She's like battling, going through like sleep things, and I'd rather someone put ice on it than an NSAID, just because like we're training and the gut issues, et cetera, et cetera. So, I mean, ice is pretty much never, right? I mean, it really is. It's not necessary. It was used because in the 1950s, we didn't have resources and athletic trainers needed to manage. They were like not athletic trainers, but nurses on the battlefield needed to manage pain. There just wasn't a lot of like readily available things, and ice is always readily available. And that's the only reason why it got put into rehab use, was because of lack of resources. When we get injured, right, or whatever it is, we do, we can compress it, rest it, we can elevate it, light motion to tolerance, right, in time. Right? The body's going to do its job. The body will heal everything, literally everything, right? None of us, like, besides surgery specifically, going in there and taking an ACL, putting it together and wrapping it together, right, and stitching it. It's the only thing, nothing else that we do heals. No red light therapy or cupping or peptides, none of that heals specifically. All of these things can support the body doing its job. The body will do its job. Now we're really good at interfering with that and like making bad decisions, right? And so all of this is basically just to create the good situation and like surrounding effects for the body to do its job the most effectively, right?
So making sure that you focus on that warm-up is really important. Personally, I love adding some sort of eccentrics or tempo work to my warm-ups if that's something that works.
What are
with.
eccentrics?
So eccentrics are if you're doing some sort of, say for example you have, and I'm specifically thinking about the elbow right here. If you have like a dumbbell in your hand and you are slowly lowering that dumbbell super, super slow. So maybe 4 seconds on the way down and like 3 seconds back up. You can do the same thing with your hand facing up. 4 seconds down, 3 seconds up. So an eccentric is something where you're prioritizing the negative of the movement and taking that really slow. Those I would say are super helpful to add into a warm-up. I do think that people rush to stretch when most of the time, we may not need mobility, right? It's like, oh, like something really hurts, I'm gonna go and stretch it. Like, yes, maybe, but maybe that's not necessarily what you need, right? Like if your mobility is good, if your range of motion is good, you probably don't need to spend extra time just stretching, right? I would much rather you at that point spend more time loading the tissues with eccentrics, light loads that you can tolerate, stuff like that. So for those sorts of issues, like if something gets better with warm-up, I would prioritize those sorts of movements rather than just like going ahead and stretching everything.
Yeah, I think it kind of comes to the point of like more exposure at lighter intensities is good, right? Very similar to what we were talking about with like the snatch and stuff, like time under tension is key. Most of pain and how we treat it is like just currently we don't tolerate X, Y, and Z because of maybe some other things, but most of what rehab is just increasing that tissues or that area's tolerance, because it's not always tissue biased or whatever. So if we have an elbow thing with front rack or whatever it is, we should probably just front rack light, like on a daily basis, not just do it when we're focusing on cleans or whatever it is, right? So like more consistent low exposure is always pretty much my go-to, right? And whatever that is, right? Melissa's more specific in like the warm-ups and things. I'm like, all right, this hinging hurt, and like, all right, we're gonna hinge every day in some capacity until it stops hurting, because it's probably an overreactive pain response to a small injury or maybe nothing structural, but we increase the tolerance to the pattern or the position over time, and then the body increases tolerance, and then those things don't hurt anymore, right? So is it structural? That's why I look at it a lot as like, what are you tolerating and not tolerating? Not like what is causing your pain, because like, I don't know, it's this area, right? I know that it hurts when I bend over. I'm like, okay, so you don't tolerate bend over, so you are flexion intolerant. So my treatment is like, that's my diagnosis. That's not the world's diagnosis. That's not like our ICD-10 codes, right? Shows you how long I've written an ICD-10 code. So I don't care about any of that. I don't care like I don't care if it's muscular or psychological. We're gonna go through a long history to talk about that and make some decisions, but all of my treatment is gonna be based on helping you increase tolerance to whatever you're not. So flexion is the specific example right now. Does that make sense? Right? And so what that does is that takes away all the weight of it possibly being biological, or when we try to explain this, everyone's like, so I'm crazy, it's in my head. No, it's not fucking in your head, oh my God, it's just part of the game. Like, it's just how it works, okay? So it's like, oh, but I really trust my docs. Like, you probably do, but like, they can fear monger you, right? And fear mongering is like basically like giving you information that's way worse than it needs to be. And so the way that I look at it and the way that I explain it to all my patients, they're like, oh man, what's wrong with my shoulder? It hurts when I go like this. And I'm like, oh, this is what's wrong. Like just this, like this is the diagnosis. What's wrong with my shoulder? It hurts when I go like this. Okay, that's the diagnosis. It hurts when you press overhead. So let's just treat that and not worry about the tissue or supraspinatus or teres minor or subscap, labrum, rotator cuff, or whatever, right? There's so much that can happen there. We went to school for way too long and spent way too much money. We would take 2 weeks to go over the shoulder on a 500-page PowerPoint, okay? And then the last 2 slides of the PowerPoint would be the same exact 10 exercises to treat it, no matter what the pathology was. It was like arm circles, muscle setting, right? And then small range of motion, active, bigger range of motion, active, resistive range of motion, right? Or resistive exercises. And so that's how we treat everything. So if we treat everything in every pathology the same exact way, why is the diagnosis important?
Right.
Right? And so that's why imaging, because all it does is it helps you or requires you to create this relationship with something that might not even be a factor. And you can't, right? Like, I have a 2-year-old, right? And so like, he sees things on TV, right? So you don't turn, like once you see it, you can't unsee it, right? And so once you hear those words in the image, right? Like torn labrum or whatever, you can't unhear that. And so this relationship is gonna be made with it, and that relationship is most of the time never good, right? So to answer the question, I always look at it as, what are you tolerating, what are you not tolerating? Which is just like treating the person and treating the presentation and not treating the diagnosis, because I don't think the diagnosis matters, right? Now that is, you can ask them, that is not the consistent in medicine, and probably why I don't practice in a clinic, but it's been my whole push for the last 8 years, is this exact verbiage and concept.
Let me add one thing before we call on Ben. So if a patient comes to see me, never do I ever give them a medical diagnosis of like, you have, like we talked about, a labral tear, impingement, this and that. Like never will I ever give them something like that, because what happens then? It goes back to this psychological of like, oh my God, I have this wrong with me. And then it just perpetuates that cycle of like, I'm not well, like I am injured, right? So I'm gonna give you something that's more of what I call a functional diagnosis, where it's like, oh, we can have an impact on these things. We can change these things. We can't really change a labral tear without going to have surgery, right? We can't have an impact on those things because they are there, right? But they don't contribute to our pain. So I'm gonna give you something that you can actually have an impact on. Like we have an intolerance to pressing overhead, an intolerance to hinging, squatting, whatever it is. There's a weakness somewhere, there's a mobility limitation somewhere. Things that we can attack head on and make progress from. So, I mean, you've had pain for, it sounds like, a long time. Right? It's a chronic issue or chronic issues at this point, which, you know, you're probably gonna be with that for a while. But the fact that you can sit here and say like, hey, I feel better with movement, like we need to keep doing that, right? Like you also have to think about your quality of life. You know, like, can you do the things that you enjoy doing? Right? So if the answer to that is yes, let's keep doing that and moving forward and progressing what we can.
When we've become from like acute or subacute to chronic, we don't use the term chronic as often, we use persisting, right? Like you have pain that's like there. It's always a good sign when like exercise makes it feel better, right? But like the sitting, etc., there's probably some like biological nuance to it, but a lot of it is most likely a learned response, right? Like the body has learned how to respond to a stimulus inappropriately, right? Like a catastrophization response, right? So when you work out, it feels great. If you can exercise, you can deadlift. I heard you talking about 2-a-day sessions. If you're doing those things and it feels good, doesn't like increase or decrease, like, or it doesn't like get worse, like when you train more, or like you can deadlift comfortably and things like that, that's a great sign that like structurally, it's probably pretty sound. Once we get into persisting pain, basically anything outside of a year, that non-specific low back pain, which is exactly what you has zero to do with anything structural in the body. Like it is, the evidence is so overwhelming on non-specific low back pain, right? So for like the stiffness, because it's basically stiffness, this is pretty much what it sounds like, right? So like after a prolonged not moving is when it gets worse, right? Most likely sitting the most, like sitting in a car for a long period of time, crushing, right? Yeah. So a lot of that, I like to like dose sitting as like part of the rehab, right? So like putting both legs straight, sitting there, because I know that's probably something you can hardly do, right? Which is like put both legs straight and sit right here. It feels like it's gonna like explode, right? And so I like to start to dose some of those things kind of specifically, maybe some more targeted like flexion bias stuff if we're trying to like kind of address it directly. But for the most part, we can be sure that it's not a structural abnormality at this point, right? Like if you can deadlift, how old are you?
60.
How much do you deadlift? 400. If you can fucking deadlift 400 pounds at 60, you don't have a structural, there's like, if you MRI'd it, you for sure have bulging discs and like degeneration and things, but everyone in here does. That's not a you thing. That's just a I'm 60 thing, right? But if you can do those things, I can guarantee that all the symptoms that you're feeling have zero to do biologically and structurally, right? They're all learned response, this aspect, right? And like the unknown, the fear of like, am I doing something wrong? Is this ever gonna go away, et cetera. But keep exercising, don't let it limit you, right? And I mean, I think you're doing all the right things for sure. So some reassurance is always beneficial too, right? Like I've talked to a lot of people like, I just need someone to like tell me if this is okay or it's not okay, right? And like I said, like we view pain as this like ultimate death sentence, right? But for the most part, most of us have beats, like we're batting almost 1,000 for most of our pain. Like it's come and it's gone. Sure, it comes back, right? But if it goes away at any point, you beat it at that point in time. So we're all Hall of Fame hitters when it comes to beating pain, right? Like, because we're all here, you've all done everything. No one has complained of pain, right? Barring just a little bit, but like we've all done the stuff here. So like we beat it all the time, right? It's just some of this prolonged, it comes back, et cetera, et cetera. So, you know, you're way more successful against the pain than like you digest it at that point in time. So while this is a long time, it sounds like it's improving over the long, like if you look at the long scheme of thing of when it's at its peak and at its worst, relying on meds, et cetera, if your pain is the same as when it was when you were on meds, you are by definition way better, right? Because you're not getting any support or any help, right? So you are improving. And I know it feels like this, like it's a long, but you are improving, right? Like your fitness is increasing, right? Okay, so then you are improving. You're tolerating more activity, right? If you have the same pain level years down the road, but your fitness and your activity levels have increased and your tolerance has increased to like other things, same level, you are by definition better and improved.
Yeah, to build true strength takes time. I would say months for sure. Yeah. A lot of people think like once the pain is gone or, you know, that's when they're better, right? But because of pain sometimes, like if we're dealing with something like that, like we may not use that arm, leg the same way that we're used to using it. So we can lose a little bit of strength, but to build that strength back, it takes months. Yeah, and it's like I said, it can be a very metabolically expensive process in the sense that like you need more nutrients to be able to heal something like that. Like if your body's using those things that you take in through your fuel to contribute to healing tissues, because how do we remodel? How do we get stronger? How do we build? With partially what we're taking in through what we eat. So we need to make sure that that's going for us and not against us.
Cool.
Thanks, guys.
Yeah, good stuff. Great.